Hello, everyone. Welcome to today's North America Community of Practice ISQua webinar. Today's topic is a critical one in healthcare, patient safety in pediatrics. My name is Ulfat Sheikh, and I've been the lead moderator for these ISQua North America Community of Practice webinars. I'm a pediatrician at the University of California, Davis, and I'm also an ISQua board member. I've been involved with the group for over a decade and a half now, and really love the networking that ISQua membership allows me. Because I'm a pediatrician, especially because of that, I was really thrilled to see this year's World Health Organization theme for their World Patient Safety Day. And as you know, this focuses on newborn health, child health, and this is really a subject that's close to my heart being a pediatrician. And because of that, I am delighted to welcome two pediatricians as our guest speakers today. While much progress has been made since the landmark 1999 Institute of Medicine, now the National Academy of Medicine report to Err is Human, adverse events are still, unfortunately, common in healthcare. They affect as many as 1/3 of all hospitalized children. And as you know, children are not just small adults. Their unique development, their physiology, and their psychosocial characteristics makes them really vulnerable to medical errors. And understanding these risks and implementing tailored solutions is paramount. So let us look at the scope of the problem. Adverse events are prevalent and they affect a significant number of patients that are children in both the inpatient and the outpatient setting. So some areas where these harms occur include hospital-associated infections, IV line complications, surgical complications, medical errors. These errors are even more critical in children due to their developmental stage, their dependency on caregivers, and the epidemiology of medical conditions, which is specific to children and may not be seen by clinicians who work mainly with adults. Other harms include patient misidentification, delays in diagnosis, accidental extubation, pressure ulcers. So let's look at why some of these pediatric patient safety adverse events happen. Why do these errors occur? And the complexity and the dynamic nature of healthcare systems pose significant challenges to quality and safety in these young ones. Certain settings are particularly high risk. So, for example, intensive care units, emergency departments. Digital healthcare is really common in many settings, especially in the setting that I work in. But in looking into the literature on digital healthcare, if not designed properly, this could contribute to errors, especially as some electronic health records may be designed for adults and could lack customized decision support for children, such as weight-based dosing, which is really critical the younger the child is. Surgical errors could involve issues such as a lack of safety culture, poor communication, or fatigue in healthcare staff. There may be a lack of pediatric specific clinical guidelines and clinical trials depending on where you work, leading to the use of therapies that are not always evidence-based for children. So looking at building a safer system, some of the key strategies to address these challenges, we do need a comprehensive patient safety approach. And this involves increasing awareness of the epidemiology of adverse events in children, and establishing a risk identification method where we pick these issues up quickly, and integrating improvement science in our work, where we look at the science of dissemination and improvement and implementation, and make sure that our work involves those principles. Central to this is focusing on a culture of safety, and this prioritizes improving systems rather than blaming individuals. So this needs a reporting culture where healthcare staff can report issues without fear of retribution, a flexible culture where we adapt things to what we do to changing demands and defer to expertise, and a learning culture that also derives conclusions from what the data we've collected from the safety information in implementing change. One learning strategy that we use in pediatrics is simulation. And you'll hear about it today in the Helping Babies Breathe program that our guests will be talking about. Simulation is really valuable because it lets healthcare personnel improve their skills and test changes in a relatively risk-free environment. So moving forward, our collective responsibility in pediatric patient safety, it's a complex area, clearly. It requires continuous quality improvement, requires research, evidence-based guidelines and solutions. And to drive progress, it's imperative that we prioritize patient and family engagement. We involve patients and families whenever feasible in identifying and implementing safety practices, and that goes hand in hand with with strong healthcare leadership and a supportive culture in the environments that we all work in that fosters patient safety. Equally important are communication and teamwork, and a lot of these simulation-based programs focus on that. We must advocate for pediatric-specific guidelines, technologies, and error reporting systems, similar to some of the robust systems that pediatric that healthcare providers who work in adult specific areas have. And by designing a systematic human factors approach and fostering a culture of safety, we can work together to prevent avoidable harm and ensure the highest quality of care for our most vulnerable patients. So at today's ISQua North America Community Webinar, I am pleased to welcome two distinguished speakers. Let me introduce them right before each of them shares their remarks. So our first speaker is Dr. Beena Kamathrain. And Beena is a neonatologist who serves as the Senior Vice President for Global Health and Clinical Skills at the American Academy of Pediatrics, an organization that is near and dear to my heart and that I've been involved with for several years. So Beena has worked at the AAP, American Academy of Pediatrics, for 6 years. She currently practices clinical medicine through Northwestern University, Feinberg School of Medicine, and Children's Healthcare of Atlanta. And in her role at the AAP, she oversees the global health portfolio of the organization, their clinical skills training programs, the neonatal ICU verification program. And the global team there does work across the lifespan, collaborating with professional associations worldwide to improve child health. And our publications reflect that. She has a range of publications addressing topics affecting neonatal and pediatric outcomes, specifically in an area that she will be talking about today, the implementation of neonatal resuscitation programs globally. So welcome, Dr. Beena Kamathrain, to the ISQua North America Community of Practice webinar. We're thrilled to have the opportunity to learn from you today.
Thank you so much. Let me share the slides here. Okay, do I have that in the right view?
Yes.
All right. Well, thank you so much for having both Hassan and myself here today. We are really excited to share some of the work that the American Academy of Pediatrics and particularly the Global Health team has been working on in conjunction with our members and our Global Neonatal Advisory Committee, of which Dr. Murali is a member. I'm first going to cover some facts. So approximately 140 million babies are born worldwide every year, and almost half of those are actually born at home, although we've been making significant inroads into encouraging facility-based births. And the most recent data from 2024 indicate that about 2.3 million babies die in the first 4 weeks of life, which is neonatal mortality, and that amounts to about 6,300 newborn deaths per day. Now, if we look at the reasons why babies are dying around the world, we often talk about the big three. So we talk about complications from preterm birth, intrapartum related events or birth asphyxia, and then infection. And that differs from the epidemiology of why babies die in high-income countries like the United States, where extreme prematurity and congenital anomalies make up a significant proportion of newborn deaths. So Helping Babies Breathe was first released in 2010 by the American Academy of Pediatrics in conjunction with other partners that you see listed there to address those top 3 reasons why newborns die. You can see that the job aid or the action plan that accompanied Helping Babies Breathe was very pictorial, and it was meant to address infection, birth asphyxia, and prematurity through simple interventions. Things like making sure that the providers washed their hands, making sure that there was clean equipment available for the delivery, making sure to keep the mother and the baby together if the baby was healthy. It also advised that within the golden minute, which is the most important time of the newborn's life, that the baby was either receiving effective ventilation or crying spontaneously to avoid the consequences of birth asphyxia. And over our first 10 years of implementation of Helping Babies Breathe with some of the partners that you see there, it was implemented in over 80 countries around the world, trained over 1 million birth attendants, and translated into 27 languages. And the studies, the evidence base around Helping Babies Breathe has continued to grow. And the early studies showed that teaching Helping Babies Breathe to birth attendants actually reduced rates of early neonatal mortality, the less than 24-hour mortality, as well as rates of stillbirths, because those babies that had previously been considered neonatal mortality just because the baby was born still, but once they were resuscitated and given that initial stimulation, those babies were actually found to start breathing. So likely they were misclassified babies, and they were babies that actually had a heart rate and responded to those basic steps of resuscitation. And in particular, Helping Babies Breathe, when coupled with quality improvement, data audits, and ongoing practice of those basic resuscitation skills, was seen to be even more successful at improving neonatal survival, that the World Health Organization incorporated this Helping Babies Breathe methodology into their Essential Newborn Care Course 2nd edition. And so you can see their job aids and action plans that were officially released last year. And you can see Essential Newborn Care 1, which incorporates the initial immediate care and helping babies breathe at birth. And then Essential Newborn Care 2, which encompasses the care that you would give to a baby after about that first golden hour after birth until discharge. And so ENC 2 covers what was essential care for every baby and essential care for small babies. So we have this successful curriculum that's based on the most updated medical science, but we also know that if we want babies to survive, we can't just develop an educational program using that updated science. It's also about how do we train people efficiently to use that science, and then also local implementation. And these factors together are what really impact overall survival. And so how are we seeing this then put into practice? One important study that I want to make people aware of is the Safer Births Bundle of Care study that was implemented in Tanzania and published earlier this year in the New England Journal of Medicine. And this study encompassed 3 years and 30 facilities in Tanzania and over 270,000 mother and baby pairs. And what they tested was a bundle of interventions that included Helping Babies Breathe training, local facilitators that were really supported in delivering high quality training, continuous quality improvement, simulation and debriefing, coupled with low dose, high frequency practice, a data collection system, and then innovative tools to help with all of the above. And what they found was really something that was transformational. They found that perinatal mortality rates decreased. Also, neonatal deaths within 24 hours were significantly decreased. There were no significant changes in intrapartum stillbirths, but what they also found was that there was improvements in maternal mortality as well. And so this bundle of care, which included low-dose, high-frequency practice, simulation and debriefing, and quality improvement, really helped improve these clinical outcomes that are really important to us to follow. So let's dig a little bit deeper in implementation, because in that formula survival, local implementation and quality improvement is actually an important part of what we need to do. So I like to share this story from one of our GLONAC members, our Global Neonatal Advisory Committee members. And he tells this story about a birth that he was aware of in a rural area in Nepal. So this is an over 2 kilo baby. There was a nurse and a helper that was present for the delivery. The baby was gasping at birth and deep suctioned. And 4 minutes into delivery, they're drying, rubbing, and stimulating that baby. They're calling for help. And a doctor finally arrives well after the golden minute has passed. They can't find the bag and mask device. They realize that the bag and mask device is in a locked cabinet. They figure that out at 12 minutes. They're looking for the key. When they open the key to that cabinet, there's only an adult size face mask. The baby is gasping and are referred via an ambulance to go to a higher level facility. The baby arrives gasping and dies 2 days later, and the death is not recorded at either place. When they do further an audit of this incident, they realize that both the physician and the nurses had done a lot of resuscitation training courses. And that the staff had been trained and responded according to their protocols for how the doctors and higher level facilities should have been communicated with. And going back to Dr. Shaik's point, the doctor and the staff were individually reprimanded for what happened, and they received pay cuts because of this poor outcome. But actually, if we do an autopsy of the health system, we actually recognize that there were a number of systemic issues at play here. It wasn't just an individual staff problem, but it was how the system was set up to support that staff and how they were called. There was a community and public health problem in how these referral systems were set up. There was an equipment problem and a logistics problem for how and when or whether the clean and equipment was readily available for this delivery. And there was a case management and skills problem, and then also a data system and feedback problem in how this death was recorded. So how can we improve and really help healthcare systems to improve, to make outcomes better using the educational programs and the evidence-based practices that we're trying to teach people about through Helping Babies Breathe and now the WHO ENC program? And I think that's really where that local context and local implementation comes in. So the AAP had the opportunity to be involved in a project in Kenya to improve referral systems for small, sick newborns. And the local hospital wanted to do what they call just-in-time quality improvement projects. And they chose a project on phototherapy, and they wanted to make sure that all the babies that were receiving phototherapy had their eyes covered and protected when they were using phototherapy. But the more that we delved into what seemed like a simple solution, making these eye shields available, well, it was very difficult for them to source the eye shields. They went to the local tailor to ask that they make these eye shields with that could be reusable. And so the local tailor made these eye shields with Velcro, but then the eye shields were being reused and they were putting them in this chlorine-containing solution to clean them. And so when I was there and trying to record data on whether or not the babies had their eyes covered, you can see that the majority of these babies, the eye shield, because of the now loose Velcro, which was affected by the chlorine, wasn't even covering the eyes. So it wasn't that they didn't understand that the babies should have their eyes covered, but there were other parts of this local context that made it that the babies, the end result that they wanted to achieve, the eye covering, wasn't actually being delivered. Similarly, as part of Helping Babies Breathe second edition, a reprocessing guideline or a guideline for how we would clean this neonatal resuscitation equipment was incorporated. And the more that we delved into this and understanding what was actually occurring, if you read this reprocessing guideline, autoclaving or steaming seemed to be the easiest things to do to actually clean neonatal resuscitation equipment. And we had a project with a hospital in Kenya where we tried to implement steaming with them, utilizing locally sourced equipment. And you can see that they were very surprised to see that some of their equipment melted with the steaming process. And this was because a lot of their supply chain was equipment that was meant to be single-use devices, but that they had to continually clean and use again because of a lack of availability of equipment that could be reused over and over. And so understanding that local context and then troubleshooting with them how they could solve this problem resulted in the picture that you can see in the middle on the bottom, which is they opted to use a chemical-based high-level disinfection protocol, but perfect that system so that that the equipment wasn't left waiting in chlorine-based solutions for over hours on end beyond what was recommended by the reprocessing protocol. So what are we doing now in this new era of E&C? So we have developed unique mechanisms to do E&C 1 and 2 training, not just in person, but also over digital platforms that allow for remote training. We also recognize that we need to support hospitals and healthcare systems to scale up their training, but also that we need to invest in sustainable coaching and mentorship that occurs after a training workshop, because the hard work of behavior change and health system strengthening isn't going to occur in just one training by itself. There likely needs to be ongoing touch points where we're having these fruitful conversations about how local implementation is going to occur. And so the AAP developed CRISP, which is the Customized Implementation and Support Package, and you can see some of the topics that are engaged in CRISP. And what happens is that we do a needs assessment with a certain site that wants to engage in CRISP, and then we customize and individualize the modules that we curate for that group of learners. Some learners may need to dive deeper into quality improvement. Other learners may need support on how they set up a training, training of trainers cascade. Others may need help with setting up a data monitoring and evaluation system. So we can really curate and individualize what CRISP looks like for that group of learners. The other thing that CRISP has been able to allowed us to do is reach humanitarian or fragile settings. And we've had the opportunity to do CRISP cohorts in South Sudan and in Somalia, where we were able to do remote facilitation using those digital platforms, and then follow that up with 6 to 12 months of mentorship using some of those CRISP tools. We also recognize in doing this work that it's not just pediatricians. And so one of the things that GLONAC is intentional about is including other partners that are needed as we're caring for newborns globally, including nurses, midwives, researchers, obstetricians. And so here are just some partnerships that exemplify the multidisciplinary nature of the work that we're doing. And Dr. Murali is going to talk in particular about our collaboration with Hexacon-M in Tanzania and some of the work that we did there with E&C training followed by CRISP. I just wanted to put a plug in. If you are interested, we do have a virtual E&C 1 facilitator course coming up. And if it's something that you're interested in attending, you do need to sign up with a partner. And there is a QR code there if you are interested to do an E&C training in the near future. And thank you. And I will now turn it over to Dr. Sheikh to introduce Dr. Murali.
Great. Thank you so much, Dr. Kamasrain. So it is my pleasure to tell you a little bit about our next speaker. So this is Dr. Hassan Mirali, and he joins us from Canada. Dr. Mirali is an associate professor in the Department of Pediatrics at McMaster University and a pediatric emergency medicine physician at McMaster Children's Hospital. His academic work focuses on both essential newborn care and child injury prevention in low and middle income countries. He has been a member of the Global Neonatal Advisory Committee since 2018 and has served as a technical advisor for several projects, mainly in East Africa. His injury research focuses on examining factors associated with child passenger helmet and restraint use, and this work is part of the Bloomberg Philanthropies Initiative for Global Road Safety. That's a multi-country project aiming to reduce road traffic injuries and fatalities. And in today's session, Dr. Mirali is going to talk about his experience with the Essential Newborn Care or ENC course and the CRISP, the Customized Mentorship and Implementation Support Package project in Tanzania. He's going to tell us about data from the project evaluations and his experience. Welcome, Dr. Mirali.
Thank you. It's so nice to be here. I see many friends and colleagues online, and it's great that you could all be here. I see more than 100 people. Next slide, please. So I'll start off kind of with mentorship, what it means to do mentorship in newborn care in person, and then we'll talk about remote mentorship after that. So I'll just mention that there's really a sparsity of papers when it comes to mentorship in LMICs in newborn care. But this was a great paper I found. It's from 2 years ago. This was an in-person mentorship project in Rwanda. They had 25 different hospitals and 188 neonatal nurse mentees. And they participated in 12 different mentorship sessions facilitated by neonatal nurse mentors. And what they did is they had 4 to 8 mentors in each of the facilities. They focused on 5 core competencies: family-centered care, infection control, kangaroo mother care, management of the small and sick newborn, and manipulation of neonatal equipment. And to evaluate this project, they had the mentors observe the mentees doing these different things with observational checklists. And what they found from the pre and post part of this project was that the competency scores rose from 42% to 75%. And of note, they didn't measure any neonatal outcomes directly in this project. Next slide. So now I'll talk about telementoring or remote mentorship. This is a project I actually did with Dr. Kamath Rain a few years ago, and we did this in 3 different countries. And for this project, we partnered with UNICEF. And so this was done in Pakistan, Tanzania, and Kenya. Initially, we selected 2 tertiary care centers in each country, and then Pakistan actually expanded that to 12 different facilities. So in total, we had 16. We did a needs assessment and came up with these topics that everyone wanted to focus on. And those were resuscitation, essential newborn care, prenatal counseling, and quality improvement. Those sessions were about an hour long, included case discussions. We put in multiple choice questions that people were able to do, and a lot of time for discussion and question and answer. Next slide. And in case you're interested in seeing this work directly, this is still available on the AAP website, all of the sessions as well as the resources that went with it. And there's a QR code for anyone who's interested in that. So importantly, I mentioned that this started in 2019 and into 2020, and the pandemic really derailed a lot of our evaluation plans for this project. And so we were able to do in-person baseline assessments, but we're not able to do the end of the mentorship assessments because that's right when the pandemic had started. Nevertheless, we were able to do a lot of focus group discussions online, and that's where a lot of our data and important lessons learned came from in this project. So I'll start with what people really enjoyed. Number one, they really enjoyed the flexibility of this telementoring project. It was location independent, which was actually critical in the end when the pandemic started. And this made it just easier for people to participate and attend. One of the words that was used by a participant was that it was convenient. They also commented on participatory learning and simulation. And this is really a common theme we see throughout our ENC programs. People really love having that newborn simulator, neonatally, and having a really hands-on session with that simulator. And then some recommendations came with it, and we've taken those forward in our other projects as well, and those are really important as well. So number one, they wanted more local buy-in. So above and beyond the needs assessment, really talking about how we're going to implement this, the schedule, the format, all those little details with the participants. They really wanted to be more involved with that part of it. Next, it would be helpful for them, and I'm sure for all healthcare workers, to incorporate these sessions into existing clinical structures. So if they're already having a rounds, to put it during that time. So it's not an extra session that they have to do. That's hard. And it became even harder when the pandemic hit and everyone was assigned to different roles. The other thing they mentioned, and this is also a common theme that we see, is more consideration of technology needs, and we really do our best. But one of the issues that we often have is connectivity problems in some area, making sure that the internet connection is powerful enough. And in this project specifically, because some of our participants had to do individual participation when the pandemic hit, they were using some of their own personal data, and so that was a cost for them. And so they just wanted us to be aware of that and have that built into our costs for the project. Next slide. Okay, so that's a bit of background about lessons learned from telementoring and in-person mentoring. And so now I'm going to talk about our most recent project that we just finished at the end of 2024, and we did our evaluation earlier this year. So this is our Tanzania Essential Newborn Care ECHO, which stands for Extension of Community Health Outcomes project. And so this is just a very big picture so you can see what the project is. Essentially, there was 3 technical advisors, myself, one person in the US and one person in South Africa. We had a team of facilitators in 6 different hospitals that we were training, and then they were then cascading the training to healthcare workers directly in their own facilities. So we started this in early 2023. At that time, we were just working with the facilitators. We did various evaluations for them, both multiple choice questions and practical evaluations with the simulators. We then did training with them on ENC1, focused on that. And then we did post evaluations for them. After that, they did their own evaluations of the healthcare workers that they were working with. During this time, that's when we implemented the CRISP program. And then at the very end, we did our evaluation of healthcare workers and facilitators after the CRISP sessions were finished. And I want to mention a big thank you to Execonum, that's the East Central and Southern African College of Nursing and Midwifery, that helped us on this project. Next slide. So this is these are the sites that we were working with in Tanzania. You can see 6 different regions throughout the country. In total, we ended up training 44 in-country facilitators who then cascaded the training down to 92 newborn healthcare workers in all those 6 regions. Next slide. So like the other projects, we did do a formal needs assessment with our facilitators, and we really, as the name suggests in CRISP, it's really customized. And so we wanted to make sure that what we were teaching and facilitating was really what the facilitators wanted to learn about and what they wanted to do better. And what came out of this was those topics that are circled there. And what all of those focus on is really quality improvement. They wanted to improve their healthcare systems, how to actually do planning and testing of changes, implementing those changes, and then incorporating QI training with their facilitators. And so that's what we really focused on for our sessions for the program. And QI was a big part of it. And one of the things that I thought was really great is that we had each of the facilitators choose a QI project of their own, get their healthcare workers that they were working with to help them, and actually implement a change and do some of the tracking around that as well. Next page. So I wanted to just take one step away from our current project right now and just talk about this very important paper. This is from 2020. Lead author is Dr. Eret, who has done some incredible work around newborn care as well. And what this talks about, as the name suggests, is that the ENC program, previously called Helping Babies Breathe, really lends itself well to quality improvement. We can really translate the education we provide to sustainable changes in clinical care and clinical outcomes. And so I'll just have you focus on the left side of the screen. So what we really want to, of course, reduce is neonatal mortality. Those we can affect by focusing on the outcome measures, which is what ENC does. It focuses on those 3 major causes of newborn deaths. And to affect those, we look at the process measures. And the process measures are really what maps well onto the action plan. These are the changes that we can start to make, start to track over time that eventually gets us to our impact. And so if you look at the right side, this is the action plan. This is what our training course focuses on. It's posted for the whole training. It's posted in the delivery rooms. This is what they're really looking at. And so looking at that, we can get to QI coverage indicators and process measures and quality indicators. The writing is a bit small, but I'll just go through the three that are there. So coverage indicator. So on the action plan, it says prepare for birth. So we need ENC trained delivery attendants. And so how do we get that? On the numerator, we have the number of deliveries attended by an ENC trained provider over the total number of deliveries in the facility. The process measures could be, for example, stimulation. So number of non-crying infants that receive stimulation divided by the number of non-crying infants born in the facility. And then very critical for us in this program is bag and mask ventilation. It's something we stress, something we really want to get started, of course, at the golden minute, which we talked about. And so that one would be number of non-breathing infants that receive BMV within the golden minute divided by the number of non-breathing infants born in the facility. And so thinking in this systems way can help us identify really quality gaps that exist, and then also helps us measure over time the changes that we're making. And this is what we really did with the participants in our CRISP program in Tanzania. I'll also just mention that Dr. Eret has a new paper just published this year looking at remote mentorship to improve CPAP use in Ethiopia over 1 year. And what was really important about that paper, we'll post it in the chat, is that it increased the number of preterm infants treated with CPAP, but also importantly, they did look at clinical outcomes and they found a reduction in preterm mortality post-intervention. Next slide. And so this is what our sessions look like. This is myself and Dr. Patul, who's in Houston, and our 6 sites with all of our participants. You can see we had fairly good participation each time. They all have their neonatally simulators, making it as interactive as possible. And I thought what was really great about this is that, it was nice to be within the same country, but different regions, and that they were similar enough with similar challenges, but different that they could also learn from each other. So, a lot of our time was spent facilitating, but a lot of the solutions to issues that came up around improving care was really from the other sites to other sites. Next slide. The other thing we did and what we talked about before, because we know with any type of simulation program, is we really need to keep practicing to keep up skills. And that's what we call low dose, high frequency practice. And so this is a model that takes neonatally, the basic simulator we have, to a next level called Neonatally Live. If any of you are interested, I have a QR code there. There's a short 1.5 minute video. You can really see it in action. But basically what this is the mannequin, an app that can be for a tablet or a smartphone. And then it also uploads to a secure online reporting system or dashboard. And what this does is allow users by themselves, if they want, or with a partner, to go through resuscitation scenarios. This gives them objective performance feedback. It logs their training data and then identifies skills gaps that they might have so that they can get targeted training for the next time. Next slide. And so this is some of our data. It's preliminary. We just have an abstract so far. We're going to be publishing a paper, hopefully in the coming months. But this is our evaluations that we did. So on the x-axis, you can see all the evaluations we did. We have a knowledge check, which is a multiple choice questionnaire. We have a bag and mask ventilator checklist, which is someone observing someone using the device and making sure they're doing it correctly. And then we have objective structured clinical evaluations, OSCEs, and there's 2 of them for ENC1. And so the baseline is in blue, the post-training is in orange, and we see this very commonly in multiple different studies. We do improve after the training, but what's really important here is that gray bar, that post-CRISP period. And for facilitators, that was a year-long post-CRISP period. And you can see either maintained or even in some cases a little bit higher than before. Next slide. We're just getting into this now. This is some of the survey data and focus group discussion data we also have. 80%, and this is from facilitators, agreed that remote mentorship helped translate ENC1 knowledge into sustained practice and increased knowledge and skills. And 100% of respondents indicated that they would recommend ENC1 training and mentorship to others. Next slide. And then our focus group discussions, and we split these up into different groups. This says master trainers, but that's our facilitator. Sometimes we interchange those words. And so what they really said was they appreciated having further opportunities and motivation to review and practice. They felt that this really sustained their learning. I love this quote that came out of it. Those ongoing mentorship sessions were further building our capacity. And then next, they also felt that mentorship helped them identify their own site-specific challenges and a path forward based on that. And that's what really where the QI came in. And so mentorship helped me evaluate my direction, plan what I was doing, and self-evaluate whether what I taught actually reached the learners effectively. Next slide. And this is from the Ministry of Health staff that we also had involved and the Execonom staff. What they really appreciated was that the virtual mentorship was easier for healthcare providers to participate in than in person. And they also felt that virtual mentorship was useful for accountability and engagement across facilities. And there's two quotes that go along with that. Next slide. And then finally, just some of the challenges that we had important to highlight. Number one was equipment, common theme, as I mentioned. This one was particularly challenging because Neonatally Live was new for almost everyone on their project. And so that was just a learning curve for people to use and learn how to use it. And then it also required an additional step where the facilitators would have to log in to a system to look at the healthcare workers' data. And so that was just challenging to get done all of the time. Internet connectivity came up again as well. Logistics, always challenging with 4 different time zones. We had TAs in 3 different time zones, and then our colleagues in East Africa in the Tanzanian time zone. And so that was just hard to get everyone into one place at the same time. Although we did really plan that ahead of time and really find the best day of week and best day of time. So I thought overall we did have good participation. Structural suggestions around not simply focusing on regional hospitals. And I thought this was like really a compliment. They thought that the training was excellent and that they wanted this type of work for the district hospitals that they receive babies from. And so really an acknowledgement of this really needs to be expanded to district hospitals as well. Next slide. And that's it. So thank you for your time. Those are all the ways you can get in touch with me. And if any of you will be at the AAP conference at the end of the month, we'll be presenting this work at the section on global health abstract session. Thank you.
Thank you, Dr. Mirali. And I will be at the AAP conference, and I hope to run into you and Beena there. I just wanted to move into the next section of today's session. So I wanted to quickly reflect on some of the things that I learned from the two of you that apply to some of the key campaign messages from this World Patient Safety Day. And then we'll move on to the discussion and Q&A section. For our audience, please put your questions in the Q&A sections, and I'll be moderating this session. Put your comments there as well. So some of the key campaign messages from this year are that children aren't small adults. They require individualized safe care, care that fits them, their age, their weight, developmental stage, medical needs, ability to communicate, and their specific context. And I heard from both of you about how your train the trainer model and your simulation basically trains not just pediatricians or pediatric healthcare providers, but focuses on training as many people in the facility as possible, so that that key message comes through about the difference in the newborn and grown-ups. The next message is safety first, always in every healthcare settings, and especially as you can see, kids are most at risk in ICU settings during complex treatments, and protecting them from unsafe care must come first. And from your presentations, I learned that, when you talk about every healthcare setting, there is that acknowledgement first that the local context is key, and learning from the local context. For example, the examples that Beena gave about the eye shields clean in a certain way that then precluded them from being really effective during phototherapy, or the single-use device that was clean for reuse given the resource constraints, and how that affected the functionality of the device and the structure of the device. All of that is really key, where when we talk about going to every healthcare setting and dealing with challenges there, we first have to step back and understand the healthcare setting. And then the next message is that the most common causes of harm are known: medications, diagnosis, infection, problems with medical equipment such as tubes or monitors that came through in your session, missed warning signs when a child's condition starts getting worse. And really, we know with newborns, you mentioned the golden minute, Bina, the first 60 seconds after birth, when resuscitation is really critical for survival and well-being. And really, we do know when harm occurs during newborn care, and your targeted training and simulation really addresses those issues. And then finally, safer care depends on safe systems and teamwork. Well-designed systems, supported staff, engaged caregivers keeps our children safe. Every voice counts. And you highlighted that during both your presentations. You spoke about the health system autopsy, Bina, for the case that you did, where the person that was had a pay cut, or personal repercussion, really that wasn't the way to go, where you actually dissect the health system. Those system level issues stand out. And then Hassan mentioned facilitators trained, who then went into training their site and really building the teamwork model that way, and making every one of us count in healthcare really was the key message there. So I really thank you for your time. And before we look at some questions or final closing comments, I wanted to remind our audience about the uh, next month. I will be attending, and I'll see you there if you're there as well, the ISQua annual conference in Sao Paulo. And I'll be there at several sessions that deal with pediatric healthcare, and hope to see many of the audience members there. And then the year after that, we actually are in Dublin, which is ISQua's headquarters. And in 2027, we're in North America, in Vancouver. So Hassan, maybe we'll see you there at the Canadian conference, in Bina as well. So lots of exciting networking opportunities and learning opportunities for those of you that wanted to know more about ISQua, who are not yet involved. We'll hear some information on access to ISQua's community of practice and being an ISQua member. That'll be all in the recording that we will share, and Sinead can share that as well. So that concludes the formal presentation part of our session today, and that moves us into the Q&A section. So let me look at some of the questions that came through. So we have a couple. And the first one, Bina and Hassan, is from Dr. Amirajru in India. And they say that India has reduced neonatal mortality, but preventable intrapartum related deaths remain a challenge. What are key global lessons in quality improvement that could be integrated into India's public health system to help achieve the Sustainable Development Goals neonatal targets faster? So specific context is India here, where some of the preventable deaths still remain a concern. So in your experience, how would you address this question?
So I'm happy to go first, Hassan, and then you can chime in as well. So I think one important thing that the Safer Births Bundle of Care study teaches us is that it's important to collaborate across care teams. So the care of the mother also affects the care of the baby. And I think when they learned how to do simulation and debriefing together across the teams, I think that was a key lesson. And I think health system strengthening is not just going to strengthen a health system for the newborn, it's also the mother. So making sure that mothers are referred so that babies are born in the best place to take care of both the mother and the baby together, I think is an important lesson. And so we need to figure out how to make sure that we're collaborating well across the mother and the baby care teams.
Yeah, I think that's really important to talk about the mother as well. And Laerdal in the type of work we do has a lot of obstetrical care as well, but involves things like having access to C-sections, having access to blood transfusions, continuous fetal monitoring. And so there's so many different factors that go into a safe birth, and we really need to tackle a lot of those things. But a lot of it comes from training. And so just having that skilled birth attendant and that person that is skilled to take care of mom and skilled to take care of babies, hopefully two separate people, is really, really helpful, and something we continuously need to scale up.
Sorry, you are on mute.
Oh, thank you so much. So the next question is about, did the training, basically QI concepts, quality improvement concepts. The question involves just trying to understand if the trainings that you delivered imparted the providers with quality improvement concepts, and thinking through some of the quality improvement concepts that I've seen similar programs address. They typically deal with trying to set a goal for improvement, rapid cycle improvements, so iterative changes that are being tested, collecting data to measure change and track very carefully. So those are some of the things I've experienced, but specifically related to the training you did, do you think any of these concepts were applied or imparted?
Yeah, sure. I can start with that, and then maybe you can join Bina. So what CRISP does is they have a whole system of a way of thinking about quality improvement. And so what we did with that needs assessment is get at what they wanted, and it was quality improvement. So we were able to take those slides and those messages from the QI sections of CRISP and present those, talk through them. They're very case-based as well. And then we had them practically do that. So when I put up that slide of the action plan, looking at the places in their hospital, in their context, where do they see are the issues? And then getting into, are these the issues? How do we measure that? How do we measure it over time? What changes are we going to make? And so yes, there was a lot of QI, both formal training and discussion, as well as practically how do we get at that and improve quality.
And maybe I can add that even preceding CRISP, when you're talking about helping babies breathe or now essential newborn care, there's this palpable excitement when you attend a training, as people go through the training. By the end of the training, they are very excited at the new skills and knowledge that they have acquired. And oftentimes there's a sense of, oh, wait, I used to do this. I used to pick up babies and hold them upside down and slap their bottoms to get them to breathe instead of, stimulating their back. And so it lends itself easily to these questions of, what did I do previously that I'm no longer going to do? What are things that I've learned that I need to put into practice, and how am I going to make that practice? And so how am I going to make that happen? And so even though we're not using like the specific, key driver diagram or technical words, we're starting to introduce the concepts of QI with these simple questions, and also provide some prompts about what the indicators are that could be followed. And what we have found is that oftentimes it's hard to incorporate those things in a full day workshop where they're focusing a lot on the skills of resuscitation. And that's where that ongoing mentorship piece comes into play and really allows, as Hassan beautifully described, people to do a project and then get mentored as they're doing that project, incorporating those QI principles. And that's where CRISP comes in. It's like the ongoing relationship that happens after that initial training to really teach about those QI concepts.
Great, thank you. And before we move on to the next question, there's a personal testimonial here that from Ludovic Loper, and they mentioned that they've seen 2 helping babies breathe simulations be done in at least 2 hospitals in Tanzania, in some way in Bukumbi. And the audience member says that they loved how they could easily expose weaknesses and practical skills and encourage real-time practice, and commends the program on those efforts. So just wanted to make sure you all saw that. And there's a question here which says, so they give you their kudos for your sincere work, and this is Hanan Alawadi, and they're wondering if you've experienced any language barriers, especially when it comes to medical terms or cultural challenges throughout the program. And if yes, how did you manage to overcome these challenges? And this audience member has 2 questions, but let's first address the one of the language and cultural barriers and challenges.
So I would say that there can be language barriers, but HBB has been translated into over 27 languages around the world. We also try as best as we can with our GLONAC, Global Neonatal Advisory Committee, to have individuals that are from various countries around the world. I think we have over 15 countries represented. And so we've been able to do trainings in Spanish and in French with the deep experience that our GLONAC members have. And then in terms of cultural challenges, one of the things that I think this curriculum really lends itself to, and also CRISP, is that it can really be locally adapted. We're not trying to solve the problems and impose what the solution should be. It's really the facilitators are there to help the learners problem solve in their own environments and within those cultural contexts. And so, of course, there are those different cultural challenges and cultural contexts. But the point is that there's a facilitated conversation and a facilitated problem solving about what the interventions may be to overcome those.
Yeah, that's I completely agree. Maybe I can answer the next one. I have an answer for that, Ulfat, if you could read that one.
Yeah, for sure. So the next part of that question, you mean the next part of
Yes.
of Hanan's question? Yeah. So the next question is, it comes from a biomedical engineer, Hanan Alawadi, says that as a biomedical engineer, they're fully aware of the long list of challenges that biomedical engineers face in low resource environments. So have you considered inviting engineers to the education program so that they can better assist healthcare workers?
Yeah, so it's a really great question because there's so much that biomedical engineers can contribute to newborn care and healthcare in general. And what I'll say is, over the years, I've seen a lot more collaborative work. Grand Challenges is probably one of the best examples, and what are called now hackathons, where they'll bring together healthcare workers, biomedical engineers, other types of engineers, and try to solve individual healthcare problems. And so I'll just mention one of my colleagues. He works in Uganda, Dr. Dada Santorino. He got a grant through Grand Challenges, and initially an idea from a hackathon in Boston, where I used to work, and was able to develop this augmented infant resuscitator, which gives people feedback about how they're using bag and mask ventilation. So I'm just going to post a video in the chat if you have time. You can take a look at that later.
Great, thank you so much. The next question I can actually bundle up with a comment that came through the chat. And so this question comes from Dr. Amiraju as well. And they say that in India, as duty medical officers, we follow the NABH standards for patient safety and quality. So that is the National Accreditation Board for Hospitals and Healthcare Providers, NABH, which establishes and operates accreditation programs in India. So they comment that they often face challenges due to limited resources and staffing. And from your experience, what practical strategies or low-cost interventions have worked in your healthcare organization to successfully implement patient safety programs despite such constraints? And then there was a comment in the chat from Dr. Inas in Yemen, again, around the main challenges in ensuring essential newborn care and ways to overcome them. So I was hoping you'd address that together.
So I think this question is a very good question. I think one of the things is one of the amazing things that Helping Babies Breathe and ENC focus on are the main reasons why patients are dying. And it's not requiring a lot of technology. It's not requiring a lot of resources. I think focusing on what is simple and doing that well. And I think as organizations become more complex, one of the things that I see happening is that we oftentimes get distracted by more technology and more complex interventions and procedures, and we forget to do the simple things well. And so I just always am trying to even bring my, complex neonatal resuscitation teams in this country. It's like, we need to focus on the stimulating the baby and then initiating positive pressure ventilation. That's still the fundamentals of a complex neonatal resuscitation, whether it's here in the US or somewhere else. And so I think, focusing on those foundational interventions is what I would say.
Yeah, I like that. And I'd also say just I think about this a lot about how do we make this sustainable? How do we make this long term? And we've really gone from these like individual trainings to more longer term engagements, especially with the CRISP program, getting the mentorship in progress. And I wonder how we can just keep staying engaged for questions as they come as needed. Actually, I'm still on the WhatsApp group from this project, so maybe that's one way where we can maintain people's interest and have someone available as a resource person. The other thing I'll say that I've seen work well is having a quality improvement champion, some person that is there that perhaps has gone through this type of training before, that is really interested in this, and they can really be the lead for their hospital and take over that role.
Great, thank you so much. And we're at the hour. There was one final question about, did you make how do you do post-training follow-up, and after how many days? I did put in a link that someone else had posted to evaluation assessment tools there in that answer. But I wanted to see if we could conclude this session with you just talking about what happens once people are trained in terms of follow-up and evaluations.
Sure.
You did address that during your session, but I just wanted to try to conclude with that as the last question as well.
Yeah, sure. So a couple of ways we can do that type of evaluation. We do have what's called a knowledge check, which is a multiple choice. So that just assesses people's knowledge. We have observed bag and mask ventilation skills. So someone's actually using the bag and mask ventilator on a newborn simulator, and the evaluator is doing a checklist for those. And then there's ISQs, which are a very common way of evaluation in medical settings, and we have those formalized as ISQ A and B for the ENC one, and then there's also the same thing for 2. And so that's the way we're evaluating people. And then, like I said, Neonatally Live. Hopefully, this will get utilized more, but that provides its own evaluation at each session and gets uploaded into the cloud, and we can see that over time as well. So those are, I'd say, the main ways we do it now.
Great, excellent. And with that, I'll bring this fabulous session to a close. Thank you so much, Beena and Hassan, for your engagement and for sharing your work. And most importantly, for doing what you do to take care of our babies, to make sure that they have the healthiest, best possible life forward ahead of them. Healthy babies make healthy grown-ups, and really that's what makes our world go round. So really appreciate your time and effort. And the audience, thank you so much for your engagement. I look forward to seeing many of you in person next month, but definitely all of you virtually in future ISQua North America Community of Practice webinars. We're generally every month or every 2 months. So see you there soon, and have a good rest of the day. Bye.
Thank you.